The content herein is for informational purposes only, not intended as medical advice, diagnosis or treatment, and is not to be substituted for direct advice from your doctor.
Consisting of a mobile controller, compact garment, and an optional app, Dayspring delivers multiple modes of compression in a single treatment. With Dayspring, you can go about your daily activities while receiving treatment anytime, anywhere.
Greetings and welcome to our LymphCast show, episode 60 tonight. That's right, the big 60. We want to remind you to visit our website early and often, and that is lymphcastnetwork.com. If you have a question for one of the doctors on the panel, you can write to us by email, hello@lymphcastnetwork.com. And a reminder that this show is on every podcast platform under the sun: Spotify, Google Podcasts, Castro, Apple Podcasts. We are everywhere. And every show is on YouTube as well. How about that? Well, let's go around the room and meet everybody tonight. From California, one of our panelists from the very beginning, Dr. Emily Eicher. Hello, Dr. Eicher. How are you?
Hello, Paul and wonderful team. And we are so grateful to have Dr. Maldonado today for the 60th show on the road. So LymphCast, everybody welcome.
That's right. And we are off and running. The gentleman who started all of this, he is a physician and surgeon. He's also the founder of Vital Support MD. They make Vein Formula 1000, Lymphatic Formula 1000 from New Jersey. Physician surgeon, Dr. John A. Chubak. Hello, Dr. Chubak. How are you?
I'm doing fine, Paul. Thanks very much. Great to be here again tonight.
You bet. One quick question for you, Dr. Chubak. I didn't prep you for this ahead of time, but I'll just put it out there. To be sure, so our listeners know, you've developed Vein Formula 1000 and Lymphatic Formula 1000. They can get those products on their own, right? They do not need a prescription. Is that correct?
That's correct. Those are over-the-counter dietary supplements, which they can find at our website or Amazon and in some pharmacies around the country as well.
Okay, they can order them during the show. How's that for an extra bonus? I'll turn it back to you, sir, if you want to bring in our special guest, and then we will take off and get the questions going.
Sure. Well, tonight we have Dr. Thomas Maldonado on the show. It's Dr. Maldonado's second appearance on the LymphCast podcast. And he's, I believe, one of the only guests who's back for a second time, although we promise many people such an opportunity. We don't always keep our promise, but in this case, we certainly have, because his level of expertise puts him in a very special category. He is professor of vascular surgery at New York University Medical Center in New York City, and like myself, he came from a family of doctors and had a strong medical background. Dr. Maldonado has a very special interest in minimally invasive procedures for taking care of various aspects of the circulation, both the arterial side of the circulation and the venous side of the circulation, and has been quite a pioneer in those areas, doing some very specialized work, which is helping to move medicine in the United States and around the world forward. I had the good fortune of seeing Tom recently at the Eastern Vascular Society annual meeting in Charleston, where we had the opportunity to meet in person for the first time, which was very nice. So I feel privileged now to call him a friend as well as a colleague. So Tom, welcome tonight to tonight's show.
Thank you so much. It's great to be here. I don't know if something I slipped through the cracks, you got sloppy there, or if I did something right the first time to be invited back, but it's really an honor for me, and I really enjoy it. I think it's one of these really important podcasts to educate all of us about lymphedema, swelling, venous disease. It's an honor to be here. So thank you for inviting me again.
Oh, you're quite welcome. So, tonight's program is going to be a little bit free form. We're going to have, as we always do, a very natural and spontaneous conversation. But I do know that Dr. Maldonado has just finished up some work, and wants to share with us. Maybe that's a great way to get the ball rolling this evening. Some work he's done on what's called the TEASE study. So Tom, could you talk to us about the TEASE study and what that means?
Yeah, I find that, you mentioned that I do a lot of sort of work in minimally invasive surgery, et cetera. And for me, what's interesting and frustrating about lymphedema and these type of problems is that there's not great options, treatment options sometimes for patients. And this study looked specifically at pneumatic compared to non-pneumatic pumps for treatment of venous lymphatic swelling, lymphedema. But of course, we know that venous disease plays a big part in lymphedema. And what it did is it was a nice study design where we randomized patients prospectively, took patients and randomized them to receive both pneumatic and non-pneumatic treatment. And as I'm sure we'll get into, the traditional sort of pneumatic pumps, of which there are a number, especially the advanced pneumatic pumps, have been very important in managing patients with this disease, giving them a lot of autonomy, et cetera. But the non-pneumatic pump is a very novel device made by Koya Medical. It's named the Dayspring pump. It has an upper and lower extremity device. But this is a device that, unlike the pneumatic devices, which require to be plugged into an outlet, if you will, and have the chambers filled with air sequentially, this relies on sort of a smart alloy metal frame that constricts and relaxes, expands and constricts rather, and allows that massage or that sequential compression to occur while the patient walks around, right? So it's a little battery pack that delivers current into these flex frames in a very nice, elegant way, allows patients to be mobile. So it's remarkable. This company has done a fair amount of research already. We've done, upper and lower extremity now trials comparing the pneumatics and non-pneumatic. The Nile study was the upper extremity trial, and this is sort of the sister trial looking at the lower extremity, comparing the Dayspring non-pneumatic device using this sort of smart alloy, patients walking around with the battery pack on, to the traditional pneumatic device. And what the trial did is it randomized patients to either treatment. And then after a washout period, which is a very validated study design where patients got neither for a period of time, they would swap to the other. So they'd be randomized to one, they'd wash out for a period of time, about a month, and then they would swap to the other one. And so at the end of each of these treatment arms, we would measure certain outcomes. Of course, limb girth is the obvious one. But the other equally important is quality of life, patient satisfaction, things like this, which I think all of us, Emily will speak to this, but I sort of talk about these patients as sort of orphan patients who are very frustrated. They don't have sometimes a lot of options, and quality of life is an important endpoint, right? So we looked at endpoint, quality of life, limb girth, compliance, satisfaction, all these things head to head. And much like what was found in the upper extremity Nile study, the TEASE study for the lower extremity found, really superior outcomes for these metrics with the non-pneumatic device. And there's a lot of reasons that may be true, and we can get into that. But of the 71 patients that were randomized, at the end, looking at these outcomes, we found better compliance, better outcomes with limb reduction, volume reduction, and quality of life. So it's exciting because I think that, again, we really do need more research in this field when it comes to sort of and of course the randomized trials are really level one evidence, if you will, right? So these are really a good, I think, solid data, very multi-center study, very rewarding for me personally because I'm a big believer in this. So anyway, that's sort of a 30,000-foot view of the trial. And I think it's been presented at the American Venous Forum last year. It's going to be presented again this year at the VEITH Symposium, and it's in publication now. It should be in the JVS or JVL, the Venous Lymphatic edition of the JVS coming out next month. So,
well, that's phenomenal. It comes at an appropriate time in my personal clinical practice because it's only very recently that we started using the Koya Dayspring device, and the initial feedback has been excellent with the mobility and ability to get around with a small battery charged unit and so forth. And I had always been using pneumatic compression up until this time. I mean, in addition to obviously graduated compression stockings and non-stretch bandages and things like that for patients with venous leg ulcers and so forth, going back to the teachings of some of the greats like Hugo Parch and folks like that, who I know Emily knew quite well. So as far as electronic devices, the Dayspring is new to me, but it's a fascinating technology as you described it, being non-pneumatic. And one of the things I wanted to ask about, Tom, before I pass it over to Emily for a few questions, if I understood you correctly, you mentioned something which for me is new in terms of study design. I'm not saying it hasn't been done before. I'm not an academic who's paging through all of the journals every single day, but did your design involve, are you telling us that the two devices were eventually worn by all of the study participants? In other words, they'd be in one group first, and then there would be a period of normalization, or you called it washout, and then they would switch to the other device to see how they responded. Do I have that right?
That's correct. So there's an initial washout to sort of start with a clean slate, if you will. And then they were randomized to one or the other device. And then after a comparable washout, they switched to the one that they didn't get, right? And so you had this sort of, you're trying to eliminate bias, because perhaps if you always got the same device first, you might have a certain impression. So I think that this is a well-established study design, this crossover study. And I think it allows you to kind of have internal control here too, because the same patient receiving both devices, right?
That's great. Okay, this crossover concept. Yeah, now that you say that, I am familiar with that term. So was there any tendency for particular patients that I know it's a relatively small group with 71 patients, that may have for some reason responded better to one device or the other, or you didn't see that kind of tendency?
Yeah, I mean, I think that it's a 71 patients, a fairly small number of patients. Some patients have had phlebial lymphedema. There was a subset of phlebial lymphedema patients versus non. We're looking at that now a little bit better to try to tease out which one might have responded better to one or the other. But across the board, I think that there was a really superior outcome for the non-pneumatic. One of the things that the reasons for that we can stipulate, but is that it's sort of a threefold effect. One is that you have this sequential compression, which is common to both. The other is that you have a static compression. Part of the device has static compression to it, which I think is very important. And then you have the sort of synergy with the muscle pump in the calf by being mobile and exercising. So I think those three kind of, the trifecta of those three is what I think makes for the difference.
Was the time worn daily equal in both devices?
Yes.
Yeah, right.
That was controlled for, and then that was what we measured compliance based on too, because patients were asked to report how compliant they were with the device. So it's interesting because compliance is something that we talk about, and I always say, well, if you're using something more, then you're going to have a better outcome, and so maybe perhaps there's some criticism of that. On the other hand, I would argue that what's the use in prescribing something that is not going to be used, right? It can be the best, silver bullet in the world, but if you're never going to, pick it up and use it, it's futile. So I think compliance is something that's not really talked about a lot. Certainly was the Achilles heel of the sock study. When people talk about, using compression socks for PTS, for post-thrombotic syndrome, that was a negative study, if you will. But the big critique was whether patients were using the socks to begin with, right? I think that this is an important.
Emily, I'm sure you have some thoughts, questions.
Yes, a wonderful study. Thank you so very much for doing that. How did you select your patients? And do you have upper extremity lymphedema patients, lower extremity, primary, secondary staging?
Right. So the upper extremity lymphedema patients were a separate study. The acronym for that is NILE, N-I-L-E. And that's a similar design with similar outcomes. It was designed as a non-inferiority study, but it ended up showing superior results for the non-pneumatic. In this particular study, I can tell you that primary lymphedema was about 11 of the patients. Secondary was about 60. So most patients had secondary lymphedema. Patients did need to be able to be mobile. In other words, they had to be walking around. They couldn't be patients who had stroke, patients who were immobile were not really good candidates. But other than that, it was patients who had established diagnosis of lymphedema, and that was the breakdown. It was basically mostly secondary lymphedema, some primary. Stage 3, about 14 patients. Stage 2, 44. There was a breakdown. The majority were stage 2 or 3 lymphedema patients.
And you mentioned phlebo-lymphedema. How many of those did you have?
Yeah, the phlebo-lymphedema, I have to go back and look. We're doing that analysis right now, but it was, about a third of the patients, I believe, had some degree of venous insufficiency, maybe more. I'll have to go back and look at that. But that's going to be an interesting comparison, right? In my experience, phlebo-lymphedema, and I think across the country, is really the dominant secondary lymphedema. We used to think cancer was the most common form of secondary lymphedema, but I think venous insufficiency is. We'll stay tuned for that. That's going to be a spin-off manuscript or study. We're going to look at that comparison between the phlebo and non-phlebo.
Very interesting study. And what was the time frame of the study?
So there were 2 treatment arms, if you will. So they had initial washout of 28 days, and then they were treated for 90 days. A washout of 1 month, and then the other 90 days for the other treatment arm. So we're talking about a nearly 7 months, 8 month study because 3 months for each.
Well, compliance is very, very important, and to check the compliance of the patients. And what was the outcome, and how did you measure the outcome?
Well, the outcome, as I said, the primary outcome of quality of life was measured based on the LymQual scale. Quality of life is a validated scale for lymphatic for lymphedema. That has 6 subsets, as you probably know, based on activity, social, psychiatric, and that was the scale that was used to measure quality of life that showed significant improvement or superiority for the non-pneumatic. The other was of limb volume itself, measuring limb volume. Was the other primary endpoint. And then the sort of secondary endpoints looking at compliance and patient satisfaction.
Right. Well, as you know, I see a lot of clinical patients. And in terms of using what we call manual lymph drainage protocol treatment, where we do administration of the lymphatic drainage followed by a compression pump. And we do have the static sequential pumps. Patients are reporting that this is wonderful when you do it, when I am done with the treatment after 1 hour or 1.5 hours or 20 minutes or so. But then if I don't put the stocking on, the volume comes back. Do you see that the same?
Consisting of a mobile controller, compact garment, and an optional app, Dayspring delivers multiple modes of compression in a single treatment. With Dayspring, you can go about your daily activities while receiving treatment anytime, anywhere.
Well, yeah, it's unfortunately not curative, that's for sure, right? So it's about maintenance, and I think that it is the same. I think that and that's why, to your point, compliance becomes so important. Because if you're not compliant and you don't stick to this or manual lymphatic drainage or what have you, you're not going to have lasting results. What is interesting is that we looked a little bit at the use of compression stockings, for instance, and we found that those who use the non-pneumatic device, the Dayspring, seem to require or use less compression socks adjunctively, sort of at the same time. So they relied on it less. What that means is hard to say, but it perhaps because they had more long-lasting results.
And with Koya, which is a wonderful design, which starts with lower extremity, and I think lower extremity is a little bit more challenging, as you know, than upper extremity. But with lower extremity, the Koya sleeve starts from ankle and progresses up to the below the knee and so on. Do you have any negative increased volume in the foot and ankle?
That's a great question. We have, well, two things. This study in particular did not notice a difference between devices with relation to the foot and ankle. But what we did here at NYU, we were very interested in this, and this is one of my first sort of apprehensions about this, was what happens to the foot and ankle. And we took this now, not the T study, but a separate study that's in review now, should be in publication soon. We took patients who had just the Dayspring device. We did volumetrics through volume displacement in water immersion, and we measured volume of the foot and ankle before and after use of the Dayspring. And we found actually that there was reduction, because again, I think that it's not so much the compression on the foot and ankle, but the fact that patients are mobile and they're clearing proximally, and they're allowing the foot and ankle to actually reduce in volume. So just the opposite. I don't think that there's an increase. I think that you actually have improvement in the foot and ankle swelling when you have this type of treatment. And I think that also speaks to the mobility of the patient. I think that probably is a big component of this, is the fact that they're activating their calf muscle pump when they walk.
Yeah, it's interesting. And it does make sense physiologically. It's sort of counterintuitive. And I understand Emily's question, because it's counterintuitive to what we've always been trained, especially with static compression. You know, we don't want our patients wearing, let's say, a compression sleeve that ends at the ankle, because we're worried about the foot swelling because of a tourniquet effect, et cetera. But in this case, you know, it almost reminds me of cardiac surgery in the sense, you know, that with the venous return, when you have that activation of the venous system and the lymphatic system, it's almost a siphon effect. I mean, you're priming that system and that pump, and it's literally drawing fluid up out of the foot. That's the only way you could really justify or explain that reduced volume in the foot that you tested, which is I think a fascinating finding. It's amazing.
Yeah, and I think also using the volume displacement with the water immersion was something I insisted on when we did that study, because I find that when we do, you know, circumference or girth measurements, it can be a little bit imprecise at times. And I was really pleased to see that we were really, you know, we had pretty impressive, you know, difference and decrease in volume, you know.
And from a patient's point of view, for somebody who's been, you know, taking care of these patients for 15 years or more, that's a wonderful advantage, because a big concern is, how am I going to get a shoe on? What am I going to put on my feet? So if their foot is not obstructed by, let's say, another compression garment on the dorsum of the foot, around the foot, the body of the foot to the base of the toes, that really has a massive quality of life advantage for these people.
Yeah. The other thing, Emily, about that this study we did, which will come out, is we gave them pedometers, like Fitbits, right? So we would know that they're actually walking, right? It's one thing to give a patient a prescription for this, maybe to help them fit and see how it works in the office. But then what happens when they leave the office? And in fact, these are all patients who were highly active and moving and walking, and that we were able to control for and capture with these Fitbits. So
interesting. As you know, I do a lot of ultrasound before and after. It would be interesting to combine your study with ultrasound as a baseline, and then perhaps at the end of the first hand of the study, first 28 days, and then at the end of the study, after the several months, to see what are the subcutaneous changes, what are the changes in the fascia in these patients.
Yeah, that's a great idea. That's interesting. I think the more objective metrics we can get to sort of, you know, describe, you know, outcome, the better, right? I think that's what's lacking, I think, a little bit in this, you know, and perhaps it's because we don't have the tools, you know. Yes. But I think that's an important point, is we want to try to objectively gather data on outcomes.
Yeah, well, this has always been in the world of lymphedema, lower extremity swelling, et cetera. All of these factors have always been kind of the stumbling blocks to producing high quality studies. I know in the work that Monica Glavitsky did for many years, looking at MPFF, one of the biggest frustrations and challenges was standardizing a way to measure the limb. And that's actually one of the reasons we feel so strongly that for a long time, the venous leg ulcer data with MPFF was superior to the edema data, was because with a venous leg ulcer, you have something very, very
Concrete
to look
Yeah.
at. You know,
Yeah.
I mean, there's your ulcer, and is it getting smaller, and is it healing, and how long does it take to fully heal? Plus the fact that in those cases, when you talk about compliance, the patients were highly motivated to stay in the studies and follow up and so on until they got healed, as compared to people who just have swelling and so forth, where, not that it's not an important
Right.
issue, obviously it's the whole purpose of our program here,
Yeah.
and it's meaningful to people. But when you have an open venous leg ulcer, you're really highly motivated to stay in the study. So to your point, Tom, it's historically been a challenge. And I think that volume is, and fluid displacement is perhaps the best way of checking. But I agree with Emily. It would be really interesting to look at those changes. Typically on ultrasound for people with really advanced edema of the lower extremity, we have that so-called ant farm appearance where you can actually see the edema. But in some forms, we don't see that for a variety of reasons. You don't see that ant farm appearance, and especially I think with more chronic non-pitting lymphedema
Fibrotic,
patients, things like that, with fibrosis, and even some who then, of course, develop lipodermatosclerosis. So these are all challenges. I mean, it's a really difficult thing to gauge.
Interesting about, since you bring up leg ulcers, I'm interested in sort of, studying this in both with the Dayspring, but also with other devices. The problem with leg ulcers to me is that you have this multifactorial component, right? You can have infection, you can have arterial component, venous component, you have the chronicity of it. And so I always wonder how to control for that, right? I suppose, I don't know what your thoughts are on that. How would you design a study to control for all these other factors? Because that's been a little bit of a hurdle.
Well, I don't know that I can give you the answer to that, but I can give you an interesting insight. This I've always found fascinating. And I know what the follow-up question is, and I don't have the answer off the top of my head, but in the guidelines, the American Venous Forum guidelines, Society for Vascular Surgery guidelines for venous leg ulcer, which is going to be redone soon. I think Mark Meisner is going to be heading that up. But the old guidelines are from 2014, so they've been standing for quite a while. And they had been, I believe, a 1B previously. But for micronized purified flavonoid fraction, they found the greatest effect in what they called long-standing or large venous leg ulcers. So chronicity does make a difference, is my point. Ulcers that are newer and obviously smaller, but even if they're larger but acute and not long-standing, are more likely to heal completely and faster. So in other words, with the MPFF studies, the greatest benefit was seen in those patients who had long-standing non-healing ulcers and had everything else done and were having everything else done. And then the MPFF was added. So all I can say is you're barking up the right tree, in the sense that that's a very important question to ask. Is there value in that device for an acute first-time ulcer, a long-standing non-healing chronic ulcer, or potentially, let's say, a recurrent ulcer? So because the physiology is different for sure.
Yeah, I think you just have to control for all that. It's probably these require larger, a larger study with more patients, I think, to really look at this. But I think it probably will be positive. Those studies will probably be positive. It's just how to glean, the nuance out of it with chronicity, infection, whether there's an arterial component, et cetera. One of the things, speaking of arterial, that there's always this sort of a big question I get and I'm sure you must as well, Emily and John, is compression in general when you have arterial insufficiency, and what is the threshold at which point you worry about this mixed etiology, right? And I'm pretty liberal about using compression even in arterial insufficiency, unless we're talking about, ABI is under 0.5, 0.6, So, I don't know if you have run into that problem yourself, or if that's something I just seem to be hounded with, these concerns about, no, you can't put a sock on because you have, PAD.
Yeah, I'd love to get Mark Moline's thought on that. Again, historically going back, I think the classic advice or training was, ABI 0.8, below 0.8, you really have to begin to worry. But like you, Tom, I blew past that parameter a long time ago and really never felt that I hurt anybody, by doing that.
Yeah.
But by the same token, the other place where, and we've talked about that a lot on the show, where years ago when I first started in superficial venous disease, outpatient treatment with ablation and so forth, and Emily and I have had this discussion and other guests, I was actually quite terrified in the beginning to ablate an incompetent saphenous vein in somebody who clinically looked like they had lymphedema. Now, when I think about it now, I almost want to laugh. But you and I grew up in surgical residency, and Emily started in surgical residency, and unfortunately, her lymphedema cut her surgical training short, and she switched gears. But we all remember back in the day, and I talk about this a lot, especially after modified radical mastectomies, where a lot of lymph nodes were being taken from the axilla. We were so paranoid to do anything to the ipsilateral limb, even take a blood pressure, forget about put an IV in or draw blood. So when I first came into this field and was transitioning out of cardiac surgery, and patients would come with, rip-roaring venous insufficiency in the great saphenous, but they were, had signs of, not just signs of what I would call edema that is typical of venous insufficiency, but people who really looked like lymphedema patients. And this whole area is getting gray now, but they really had classic looking lymphedema, probably people with primary lymphedema who then developed venous insufficiency. I was really afraid to intervene on those people. And then eventually when I had ulcer patients, I felt I had no choice. So I treated them and they got better. And then I started treating everybody and they all got better. And now that I understand phlebo-lymphedema much better than I did then, I didn't understand it at all back then as phlebo-lymphedema. Now I never hesitate to treat those people. So it's interesting how we grow up with parameters and guidelines and cutoffs like the ABI, or, you have to be super cautious about, causing any trauma in a limb with lymphedema and so forth. And that brings me, and I'll put that back to the rest of the panel. I was blown away, absolutely blown away, when we had Harkin Borson from Sweden on this show, and he showed us his liposuction results on patients with tremendous lymphedema, primary and secondary lymphedema. And I thought, oh my God, you're gonna kill this patient. They're gonna lose their limb, And his attitude was, yeah, that's absolutely wrong. He said, when the lymphatic system isn't functioning, you can get rid of all of that tissue with impunity because the lymphatic system isn't working. It's sort of like when patients ask you, well, what's going to happen, if you get rid of this vein? Like, where's all that? They say, no, you're going to get better when we get rid of the bad vein. Your circulation is going to improve. And that was Brorson's point with regard to a failing lymphatic system. If you do an extensive, aggressive liposuction, you're not hurting the patient, you're actually helping them. So I think we're relearning a lot of truths based on a lot of old information and knowledge.
Yeah, I mean, I don't know about, I'm a little bit timid about jumping on that bandwagon about the liposuction. I understand it in principle. I think like anything, there's a spectrum here, right? And there are probably those very advanced cases where the lymphatics have been burnt out completely. But then, and for that matter, there are those patients who just, anatomically have huge redundant, lymphedema in the thigh and have to have debulking surgeries. I think there's a lot of value in that. We can talk about surgery for lymphedema. We have actually at NYU, we have a new colleague who's just joined the plastic surgery division, doing a lot of lymph node transfers. And I know that Peter, in particular, Glevitsky is a big champion of this. It's always a little more complex in the lower extremity than the upper extremity, I think. I don't know the outcomes are as good, but I think that's the future, right? I mean, that's going to be an important part of the armamentarium that's yet to develop is surgery for lymphedema.
You know, we talk about it all the time on the show. It's not going to be me doing it, unfortunately, but if I could turn back the clock 20 years, it probably would have been, because I find it so fascinating between the lymphovenous anastomosis, lymph node transfers, and the role for liposuction and debulking surgery and so forth. And in my opinion, I mean, you're really talking about one of those places where science and art overlap, and great judgment and great technique. And it's a challenging area, but I think that it is definitely the future in many ways, because there are so many people suffering with significant lymphedema that, you know, all of these processes and techniques we're talking about are great and wonderful, but it's just, I think in a way, heartbreaking to think that there are surgical, you know, options, treatments, and even in some cases solutions for people who are really suffering. And the vast majority of those patients historically have been offered none of those options. So
yeah,
I hope that a program like ours and discussions like these and the work that good people like yourself are doing is going to pave the way for a generation of young surgeons to come who are treating that on a regular basis with great results.
Yeah, it's not too late, John. You can still go back and train.
Tom.
You can go back and train. Do one more fellowship.
Way too late for me. Way too late. But there are plenty
John,
of people.
Yeah, I just want to point out that on the West Coast, we have a few surgeons, and I have seen a very good outcome from lymph to vein anastomosis in lower extremities, or even lymph node transfer. And we have Dr. It used to be in a KEC, Dr. Patel, now he's with the Cedars-Sinai, and Dr. Granzo, he even partnered with Dr. Hakan Brorsson in Sweden for a short period of time, where he learned his technique. So yeah, we do have surgeons, but again, this is not a curable condition. And if conservative management fails, then we have now options which decades ago we did not have. As you pointed out, lymph to vein anastomosis is frequently done, and less frequently, but if medically necessary, we have lymph node transfers.
At VitaSupport MD, we believe in creating the best bioflavonoid-based supplements to support your vitality. Bioflavonoids are found in abundance in nature and support excellent health and wellness. The demands and stresses being put on our bodies in these challenging times are unlike any we have seen before. Support your body with the flavonoids it needs to fight inflammation and oxidation. Unlike other products in the marketplace, VitaSupport MD dietary supplements use micronized flavonoids for optimal absorption and effectiveness. Micronization is an advanced process which creates an ultra-fine powder easily absorbed by the body. At VitaSupport MD, we are passionate about making your good health our life's work.
Yeah, and I think one of the interesting things, to Tom's point, I certainly agree that patient selection for those liposuction cases is critically important. But everybody has their bias. In other words, I remember quite clearly that, and here's an area that I don't necessarily agree. I don't have vast knowledge, certainly not personally with it, but he was quite down on lymph node transfers and lymphovenous anastomosis, and quite skeptical of the results and so forth that have been presented around the world. So even Dr. Borson, who I have great respect for, he knows this. I've spoken to him about it. I think he comes to it with a certain bias for his preferred procedure. But I think ultimately, like anything else, like any great surgeon who specializes in a given area, you need a toolbox filled with lots of options and alternatives, and then each individual has to use their judgment and, based on their own experience, try to tailor a plan that they feel will help the patient the most. And I think the more tools you have in that toolbox, as long as they're all effective, generally the better.
Absolutely.
Emily, I was going to ask you, have you been using the Koya device yourself in your practice, and what has your experience with it been?
I had few patients who were prescribed Koya. I see patients coming from all different regions, and there were few patients who already had Koya at home. Upper extremity, as I pointed out, it's much easier to deal with, but lower extremity is a little bit more challenging. Not only in terms of ambulation with a Koya a device, it's in lower extremity, either you have slacks that they will be wide enough to cover the design, or have shorts. And in good weather, it is very good design. And I would love to compare the study with your study to see what is happening to the ankle and foot. And perhaps I would love to try it, and I'll give you my outcome.
Sure.
I know Andy, and it was fascinating how he worked on this design and had the vision to have this design materialized for the patients who need to be ambulatory.
Yeah, I mean, I think that I'm a big fan, of course, as well, of Andy and the story. This is something that he talks about a lot. His father was actually someone who developed lymphedema, and he just thought there had to be a better way. I love hearing him tell the story, but it's a really I hate to use the word disruptive. It seems sort of cliche and cheeky. Everyone says disruptive technology, but in my mind, it really is, because it takes something completely out of left field. This is the nitinol, the nickel titanium alloy, smart alloy that we know so well in endovascular surgery. This is the metal that expands and contracts with heat, and use that same principle in this metal alloy to expand and contract these smart frames. And I really think it's been a big game changer in my practice. I understand Emily's concern about foot and ankle. I can only tell you that I took that head on with this study, and I was very pleased. But by all means, see what you think. Try it yourself. I think you'll be surprised. So long as you ambulate, I think that's an important thing. Otherwise, to your point, John, about a tourniquet effect, I think like anything, if you're going to put static compression at the ankle and not move around, then that's perhaps a problem. But patient selection is important. I tend to really use the Dayspring in patients who I know are going to be ambulating, patients who are for instance paraplegic or have dropped foot and can't walk around, are not going to have the same effect in my opinion. For that matter, the morbidly obese, patients who are morbidly obese, I think maybe best off with an alternative.
So now, from the business point of view, when patients want to have the static pump at home, Medicare can cover for the basic pump. Does Medicare cover for Koya?
Yes, I mean, it's like anything, right? It's a moving target. Insurance, and Medicare is no exception. Is the private insurance as well. Medicare is a moving target, but Medicare does in fact cover. There's a tremendous sort of expansion in coverage over the past 12 months, 18 months. A number of plans, both private as well as some of the Medicare plans, have joined and now are covering it. So, and to be clear, this doesn't require the basic pump trial that is required for advanced pneumatic compression, where you have to often use the basic pump and fail the basic pump before you get approved. That's not a requirement here. So, these are, in many ways, it is not it's not part of the family of pumps, of pneumatic pumps. It's really considered, in my mind anyway, separate from that. And I think a lot of insurers are looking at it that way.
Yeah, one of the things I'm going to do, I want to see if I can share my screen with you all. You have that option turned on, Paul?
Yes, so you should be all set to go.
All right, let's see if I can do that. So this is a very dramatic photograph from Dr. Brorson when he was on the show. I assume you can all see that, right? So this is a patient with secondary lymphedema that he treated with liposuction. Now, the first part of it is the remarkable surgical result that you see at 3 years, okay? Forgetting about the surgical aspect and going back to everything that good folks like Emily Eicher have been doing for 3+ decades, the remarkable thing about this photograph, and another reason I love doing this show, is from the pre-op photograph, where you have this massively lymphodematous limb, to the middle photograph, where the volume, so in the pre-op photograph, the volume of the right limb is 25,650 milliliters bigger than the left, okay? So what is that, 25 liters, right? But in the middle photograph, this is just with conservative therapy. Now, again, I'm blown away by this photograph. So they prepared this patient for surgery with tremendous non-surgical conservative treatment. I mean, Emily, do you get those kinds of results in your practice? Is that realistic? Is that typical? You've seen these photos before. I mean, I was blown away by that conservative treatment.
Typical, not realistic, maybe question mark. If I would have this patient for 1 month on daily basis and treating the patient, and then perhaps having Koya on and asking for ambulatory exercise and so on, maybe you can reduce some of it. But this is very dramatic.
It's dramatic, right? And
Very
then after the
dramatic.
surgery.
And usually you don't see such a dramatic improvement. And you would have to see, what is the time frame? Was it few months after the second picture, or half a year, 1 year, and how compliant was the patient, and so on. So it's interesting to see such a dramatic improvement. Surgically speaking, from the picture in the middle to the 3 years later, yeah, well, liposuction can reduce the level where it's the right lower extremity is smaller in circumference in the upper thigh than the left.
Right. And exactly. Well, you could see that post-surgically, the right limb actually winds up being smaller than the left. It's minus 90 mLs.
Well, I'd be interested. What's the patient selection for this procedure? Is there MRI? Are you looking at how do you determine that you've had a burnt out lymphatic system in the leg?
Well, I know he does DEXA studies, and he presents this quite frequently at the World Congress of Lymphology or European Group of Lymphology, and he does show a remarkable improvement. And I know the physical therapists are very dedicated. So I would summarize that this patient had manual lymph drainage and perhaps was bandaged for the longest period of time. And with the bandages, yes, you can reduce certain amount. To this extent, again, if the last one is 3 years, is this the middle picture close to 3 years? Perhaps. And if you have a dedicated patient and a therapist, yes, you can do this.
Yeah. I mean, it's the whole thing is remarkable to me. And I have to assume, it's real. I wish we had him back on the show to ask him what the time period is between 1 and 2. Certainly the results of 2 to 3 seem perfectly realistic to me. And clearly you can see it's the same patient just on the morphology of the 2 knees and so forth. So that I could expect.
Oh.
But then again, what's that?
You think it's a different patient?
No, I think it's the same patient because you can see how how the right knee and the left knee look.
No, I meant between the first and second picture. I'm not.
Well, it's hard. It's impossible for me to know that.
I know. I was like, I wasn't even going there. How skeptical.
I mean, there's some skepticism. I mean, there's some level of skepticism, but I take him at his word, certainly. Yeah. But I'm just saying, in my practice, if I could achieve that result from picture 1 to picture 2, I think I would talk to that patient. We'd be all done. I mean, I don't think I'd be recommending surgery for that person. But I think, again, we live in the United States. These are different countries. Sometimes these things are covered by, a socialized healthcare system, et cetera. I know here we have a tremendous amount of trouble getting therapy approved for patients and so forth, especially long-term. The amount of therapy for that patient to get that person from 1 to 2 is absolutely tremendous. There's no question about it. I certainly in my practice have never seen anything like that in terms of conservative therapy results. And sending them out to lymphedema therapists and, with wrapping and bandaging and hands-on therapy and, you name it. I've never seen anything like that in the United States. That's why I asked. Anyhow, there's lots to, lots to learn and lots to share and lots to see. So but again, I think it also points out that in his hands, if he's going to get that kind of post-surgical result, he's expecting that kind of preoperative preparation. He's not taking patient 1 as she appears in picture 1 to the operating room and getting the result in picture 3. He's not removing 25 liters of tissue in the operating room through liposuction. It was more like 5 liters in the end. So, you have to have a system in place. But again, people put systems in place. So if you go to Tom's, department at NYU and the, aortic, endograft program that a place like NYU has in place, I mean, people build big systems so that patients get world-class care. It's not just, you walk in the office and then I put you on for your endograft with fenestrated this and that and everything else. It's a whole process. So people who are going to take on this kind of work, that brings us back to our discussion about the future of surgery for this kind of work. These have to be specialized centers with a tremendous amount of commitment and personnel and knowledge and education and financing and so on and so forth. It's not something somebody can just dabble.
Consisting of a mobile controller, compact garment, and an optional app, Dayspring delivers multiple modes of compression in a single treatment. With Dayspring, you can go about your daily activities while receiving treatment anytime, anywhere.
And I also think that research is what really moves the needle, because to present anecdotal cases there's always that wow effect, of course. But right. What I really enjoy about some of my partnerships I have with industry, and Koya is the latest, but I have many industry partners along my career that I've done research with, is allowing sort of outcomes to speak for themselves, but in a very rigorous academic setting where you can look not just the good, but the bad and the ugly too, right? Because there are complications, and you can have, for every 3 of those outcomes, you may have one that you really don't help or may even hurt. And I think you need to really do a full thickness sort of assessment of what the impact is of these devices and these interventions are. So, that's why I'm always very impressed when I come across a company like Koya, because they are so committed. In a very short infancy of this company, they've published, 8 to 10 studies already, and it's really very rigorous. And there are other companies like that, but I just think that's really one of the metrics we have to hold ourselves to is good research.
That's fantastic. Well, I think we're coming to the end of our time. So Tom, I'm going to give you the opportunity to add anything else that you'd like, and we'll wrap it up, and then we'll say good day.
No, I just want to thank you again, Emily, John. It's a pleasure to be on with you, and you're doing great things with this podcast. So congratulations.
Thanks very much. Paul?
All right. We want to thank everybody for listening and perhaps watching tonight's show, LymphCast, episode number 60. And yes, we did start with number 1, just like everybody else. And now we're all the way up to 60. Dr. Chubak, just a quick thought on that. 60, that's a lot. And each show is at least an hour or so.
Well, my first thought is, had we started with 30, we could be up to 90. I hadn't thought of that. This is why Tom doesn't involve me in any of his research. They never get through the probability analysis at the end. But yeah, it has been 60, and it's been more than 2 years, and we've had phenomenal guests like Dr. Maldonado. And as I told him once before, you're always welcome back, and he's one of the few who's been brave enough to take us up on the offer. So I thank you for coming back, Tom, and we look forward to next time. And congratulations on a great study and great work. And we would like to, all joking aside, when you have some more data come out, we'd love to have you come back and share it with us for sure.
I'm happy to do it. Happy to do it.
Yeah, very good. And again, episode 60. Check out our website early and often. Check it every day for new information at lymphcastnetwork.com. If you have a question for one of the doctors, you can email it hello@lymphcastnetwork.com. Let's go ahead and thank everybody tonight for being on tonight's show. Dr. Chubak, you already thanked Dr. Maldonado once. Is it okay if we thank him again?
I'd love to thank you again, but I've thought of another question. I wonder, Tom, in your study, did you have any sense, you gave them a month to, what was the term you used? Sort of a cool off?
Washout.
The washout period?
Yeah, the washout.
Did you get any sense of how long because, Emily was saying, in a very short period of time, these people do swell up again without therapy. Did you track or get any sense of how long it seemed for patients to go back to their baseline leg volume?
No, we didn't monitor, limb, changes during that washout. They were permitted to use, compression socks. So that was not something off. What they were not allowed to use is any kind of pneumatic or non-pneumatic compression, right? So
interesting. It would be really great. Maybe next time around, if you're doing something like that, if you have an initial leg volume, see how long it takes them to go back, 24 hours, 72 hours, 1 week. Emily, do you have any sense of that? Is there any data on that?
I don't know if there is any data, but I did some study on just using a compression pump on lymphedema patients, and they were stage 1 and stage 2, and there was significant reduction. Short lasting, what was the short lasting? For some patients, 2-3 days, and they would come back and with some improvement, but not lasting improvement as we reduced on the very first day. And it depends on many factors. It depends how much damage was done in the lymphatic system. If someone had radiation treatments and a lot of fibrotic tissue, they are not going to improve as much as someone perhaps with primary lymphedema with partial obstruction of the lymph system in the groin area and so on. So the selection of the patient population should be also very meticulously selected.
But that's interesting, and I'm sorry if we're dragging past the hour, but I always use the analogy of cancer and sort of early intervention, because once you get to that fibrosis, you already have a much more difficult recalcitrant patient, much more difficult to treat, much quicker bounce back and relapse, if you will, of swelling. So I'm a big proponent, and people talk about when would you recommend intervention, whether it's physical therapy or whether it's pneumatic or non-pneumatic compression or just compression socks. And I really believe that the earlier you get to the patient, the better. And especially before you hit the fibrosis,
That's absolutely correct.
All right, Dr. Chubak, you want to officially, legally, and otherwise thank Dr. Maldonado.
Thanks, Dr. Maldonado.
All right. Don't thank me anymore. You're going to make me blush.
It's official.
All right. It's official.
All right. Also,
all right,
you bet. Thank you. One of our regular panelists all the way from the beginning up until now from California, Dr. Emily Eicher. Dr. Eicher, thank you very much.
Well, thank you. Wonderful team. And thank you, Dr. Maldonado, for fantastic podcast. And hopefully we will see you again with more outcome of your studies.
All right. Thank
All
you.
right.
One
Have a
one
good
more
night.
question for Paul. Now, if Emily's a regular panelist, what does that make me? An irregular panelist?
Ultra regular.
Okay, great. All right. Well, we miss Monica too. Monica, wherever you are, and if you listen in, we missed you tonight. You'd have been a great addition to the show.
Absolutely. She'll be back next time, hopefully, or really soon when she gets back in the States.
Yes.
And the gentleman who started this show, he's also the founder and owner of Vita Support MD. They make Vein Formula 1000 and Lymphatic Formula 1000. You can get each product right now, as Dr. Chubak mentioned. Go to Vita Support MD, go to Amazon. It's everywhere. You can get it on your own. Physician, surgeon from New Jersey, Dr. John A. Chubak. Thank you, Dr. Chubak.
Thank you, Paul. And for patients out there with lymphedema who are seeing lymphedema specialists, physicians, etc., don't forget to ask your doctor about the Koya Dayspring device and whether they think that that might be a good option for you. And if they're not aware of it, you should suggest to them that they find out more about it. Call one of the reps to visit the office. They came to my office and did a wonderful job. So sometimes these advances are patient driven, and we know we have a lot of patients listening. So please ask whether or not the Koya might be a good fit for you.
Sounds very good. And again, every show is in podcast land everywhere. Every show is on YouTube. Again, it's been our LymphCast show, episode 60. Have a great night. We'll see you next time.